My name is Ankur Lodha, and I'm an interventional cardiologist from Lafayette, Louisiana, and I work with Cardiovascular Institute of South. Tell me how you personally found out about IVL and incorporated it into your patient treatment algorithm. I found out first time about IVL during one of the conferences where in one of those vendor stations I'd seen the Shockwave balloon. I saw how that Shockwave balloon worked on a ring of plaster of Paris and it was able to crack that particular ring. That really fascinated me. Thereafter, I showed my interest to the reps and I was directed to attend one of their webinars. During their webinars, I really understood what the pathophysiology of how really this mechanism of intravascular lithotripsy works and how a balloon can create shock waves that could go all the way up to 50 atmospheres and create cracks in this calcium. That was the turning point where I realized that calcium doesn't really need to be treated in the luminal area like how we used to do during atherectomies, but also that the calcium which is there in the medial wall needs to be treated, and the compliance of the vessel is truly dependent on that medial calcium, and Shockwave lithotripsy goes there and was able to crack and improve vessel compliance by cracking that calcium. Thereafter, when the Shockwave balloon was first available for peripheral arterial disease indication, we used this particular balloon in our cases. We initially thought that this would be used for a very calcific case. So we brought out a case, we used this balloon, and then we realized that this balloon did a very good job in getting good balloon angioplasty results by cracking that calcium in the media and the intima and by improving the vessel compliance. We continue to use this balloon for the indications in peripheral arterial disease. However, the turning point came in when the coronary indications came in. During the coronary indications, we realized that the calcium in the coronary arteries really makes it difficult for us to expand the stents, to deliver the stents, and it really helped us understand that Shockwave lithotripsy, when we incorporate it into our patient care algorithm in coronary cases, does a great job in delivering those stents. Initially, we did intravascular ultrasound for all our cases, and we made sure that the sizing of the Shockwave balloon is complete. We realized that intravascular ultrasound was really very important and has to be done in every case where the balloon has to be sized perfectly. Nowadays, our protocol, wherever we feel that any lesion needs to be treated, we always do an intravascular ultrasound. And if we find any calcification more than 180 degrees, we employ Shockwave lithotripsy in that particular case. We have realized that there is absolutely no alternative to Shockwave lithotripsy when it comes to treating calcium. We do in almost every cases of coronary intervention, we do intravascular ultrasound, and for any indication where we see a calcification, as I mentioned, we go for Shockwave. We also do it for SFAs, we do it for infrapopliteal peripheral arterial disease cases, and we have felt that it has really improved our patient care outcomes. So, any case that we're doing in peripheral arterial disease, we see a CTA, if we see calcification in that case, when we are going to intervene on it, we do intravascular ultrasound and employ Shockwave. And in coronary cases, we also use intravascular ultrasound and incorporate Shockwave as it is indicated. Thank you.